Hi, I'm Dr. Madsen. Today we're covering Chapter 7 in the OpenStax textbook, Population Health for Nurses, and we're going to be talking about policies and regulation conditions that impact health outcomes. So as an overview, at first we're going to just talk about things that affect public health policy, then also how we balance individual rights and public health interests, as well as public health initiatives, mechanisms, and implications, and some policies that impact drug approval, supply, and costs. So public health policy comes in many forms, from legislative policies to community outreach interventions. It affects many fields like healthcare, insurance, education, agriculture, business, among others. And public health policy development and intervention happen both at the local, state, national, and global levels. It's most important to focus on public health policy and how that improves health outcomes for communities. So now we're going to really discuss some things like access, cost, and quality of healthcare and public policy, as well as influence of payment models and healthcare access and quality of care. And then we're going to look at these models and compare them, as well as their implications. So we're going to be talking about the access to cost and quality. We want to think about and assess factors that affect public policy, and this comes about through discussion and decision. So most Americans access their health care through their employer's health insurance plan. And this means that there's about 70% of workers who are covered, 36% of children, and 53% of non-working adults. The U.S. does not have a publicly funded universal health care system compared to the U.K. And then there was the passage of the Patient Protection and Affordability Care Act in 2010. And this led to millions of previously uninsured Americans that now were able to get insured and receive health care. So millions of Americans greater than 65, some with disabilities, end-stage renal disease, for example, and other chronic or autoimmune diseases that previously had trouble getting access to care now have access through this Medicare program in 1965. So Medicaid covers some low-income families, children, and individuals with disabilities. So access to healthcare impacted technology during the 2020 COVID-19 pandemic. One thing that we did see was telehealth. So this really increased dramatically, and it brought up these questions about quality and accessibility. So it really sped up the way in which healthcare institutions and providers use telehealth. So healthcare costs has a role in public health policy. The U.S. has one of the world's highest healthcare costs, and in 2021, spending on healthcare was about $4.3 trillion. This is twice as much as the average cost of healthcare in other developed countries. There really are policy changes needed in order to lower expenditures while increasing access to healthcare. Containing costs through the involving payment models is a challenge, and also improving patient use of the different insurance models. Things that we have to consider are how we can help people avoid barriers to healthcare, and some of those barriers could be just proximity, like those found in care deserts. Picture of someone using telehealth, right? So we're thinking about this. This is a nurse specialist with the Navy Medical Center in San Diego, using the Critical Care Network to provide support in intensive care units. So just new and different ways that nurses are even utilizing telehealth to provide care. So back to payment models, public health policies relating to payment models may help address problems with billing. Currently, there's a transition from traditional pay-for-service model to a payment based on the value of these services. So value-based care and alternative payment models are available. Three most common categories of payment model include the core payment model, supplemental payment model, and organizational model. Healthcare organizations are reimbursed in different ways, so they have prospective payment systems, so they pay ahead of time. Bundled payment system, for example, if you come in and have a baby, it's a set price for delivery for a vaginal versus C-section, but you don't get charged more than that, so it's a bundle. And then accountable care organizations. So recently, value-based purchasing programs have really significantly changed hospitals' approach for providing care. So for example, the hospital-based purchasing program bases Medicare payments on quality of care rather than the services performed. If a system or hospital has high rates of post-operative infection or ventilator-associated pneumonias or other negative health outcomes associated with hospital care, they receive a decreased reimbursement. So this complex reimbursement really influences how and where care is provided and to whom. So care deserts, these are areas where individuals have limited access to healthcare services. These are often in rural areas. Specifically, we see maternal care deserts, so not enough units where people can come and deliver, or OBGYNs, and pharmacy deserts. More than 80% of countries lack proper access to medical services, and there are reasons for these care deserts. So we see demographic shifts, so decrease in population, therefore decline in revenue for healthcare providers, and high numbers of uninsured or underinsured or Medicaid and Medicare enrollees, so lower provider reimbursement. So here you can see the Department of Agriculture deputy security during a groundbreaking for construction of a new rural hospital. So care deserts can be addressed in some ways, a small capacity using technology like telemedicine, more than routine care. So many areas are really left without access to emergency, inpatient, and surgical care. Some conditions require testing that's done in person. We think of things like strep, conditions like skin cancer. So there are organizations working to address these shortages. One is the National Health Service Corps, operated by Health Resources and Services Administration, so HRSA, which is an arm of the U.S. Department of Health and Human Services, HHS. This organization works to connect underserved urban, rural, and even tribal communities with those with healthcare providers that have less than 20,000 members in the area. And these providers can provide care up to more than 21 million people in over 9,000 communities. So according to the National Academics of Science, Engineering, and Medicine, nurses have a significant role in addressing these inequities. So this profession really has, as we know, we have deep roots in community health and advocacy and social justice. So there are 5 key roles that are identified. One is awareness, adjustment, alignment, and advocacy. So we're going to talk about health as a human right, implications for failing to protect this right, obligations to protect it, mechanisms to protect it, and kind of this balance between individual and public health. So is healthcare a human right? This question really has been long debated. The WHO Constitution states health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social conditions. Unlike many other countries, the U.S. Constitution does not include a right to health or health care. The U.S. government gives some support to health care over the years through Medicare and Medicaid programs and federal tax subsidies for employer-sponsored health care. But despite these programs, costs increase, leaving many more Americans uninsured. Government obligations to protect the right of health. So the U.S. is one of the only developed nations without access to universal health care. The U.S. has created an infrastructure and implemented policy and programs to health care of all Americans. The CDC and HHS work to improve population's health, and some things that they are doing are through the Healthy People 2030. So mechanisms to protect the right to health, so core components of the right to health outlined in Article 12 of the Covenant on Economic, Social, and Cultural Rights. 2018 marks the 70th anniversary of the birth of human right law through WHO, which has provided the foundation for public health. The American Public Health Association established a new human rights forum seeking to build the capacity of professionals operating in a public health space to more effectively incorporate human rights and public health practice. So public health nurses are a key part of APHA's efforts to influence health policy, and state policy influences this as well. There are tensions, we can see them every day, between individual and public health rights. This was really captured during COVID-19, right? When there was this need to have people quarantined and vaccinated versus the freedom to continue to live in a way that, fit someone's individual lifestyle. So in the United States, with its individualistic cultural emphasis, tensions really between individual rights and public health really persist. So we see tobacco restrictions, seatbelt use, helmet use, mandated vaccines. These really all triggered tensions for decades. And then this, like we said, was exacerbated during COVID-19 when we saw this pull between individual and public health. So there are 4 standards that are in place to rationalize these restrictions. One is that they need to be necessary, whatever it is, the public health issue needs to be necessary for government action. It must employ reasonable means, must be proportional to the issue, and avoid harm to the health of the individual. It's just an image of what we all lived through here, but just capturing this balance between public health and individual right. Now we're going to talk about Healthy People 2030, different policies and mechanisms of delivery, and looking at the implications of the Institute for Health Improvement, Triple Aim. So Healthy People 2030, public health initiative that seems to improve health outcomes in the United States. It includes 23 high priority leading health indicators to improve health, and these policies and programs really drive and establish mechanisms by which these outcomes are achieved. So when we think about public health policy delivery and mechanisms, we need to think about fiscal policy, so cost, regulation, so law, education, how are we teaching this, and preventative treatments, that upstream approach, and then screening for any kind of health issue that is happening. The Institute for Healthcare Improvement has this triple aim. So the U.S. healthcare system lags in factors related to access, affordability, and quality. The triple aim is a framework developed by the Institute for Health Improvement that aims to improve healthcare system performance on 3 levels. So one is improving the patient experience of care, improving the health of populations, and reducing the per capita cost of healthcare. The triple aim really recommends process, so looking at target populations, defining systems, aims, and measures to target the population, and developing a portfolio of the project work that is strong enough for changes. And this really performing rapid testing specific to the community needs is also needed. So results and benefits of this triple aim are that populations are healthier, patients receive more coordinated care, which then decreases the burden of disease and illness in the community, and this also helps with the per capita cost of population because the health is stabilized in some capacity, and the burden on publicly funded healthcare budgets such as Medicaid and Medicare is lessened, and really we see this economic well-being in a population overall improves. So now we're going to look at the FDA, manufacturing, and pharmaceuticals. So the FDA is a regulatory body under the HHS umbrella. It's a broad regulatory authority. It's responsible for protecting public health and ensuring the safety and efficacy of the food supply, medical products, drugs, and devices. One of the most recent FDA actions was the approval of the COVID-19 vaccine and expedited use of it during the pandemic. So here we're looking at the picture of the vaccine and how quickly this was able to go from production to the community. So when we think of the global drug manufacturing supply chain consists of participants at each step of the process. This takes a product from raw material to finished goods and then sold to customers. So the pharmaceutical supply chain is global, it's complex. Up to 90% of needed raw materials are estimated to come from other countries. And the supply chain quality and safety are essential to the United States' national security and public health. So pharmaceutical supply chains faces challenges, including visibility, prescription costs, and these challenges really negatively affected the supply chain during the pandemic. So Americans spend more on prescription medications than citizens of other countries, and pharmaceuticals are one of the fastest growing components of healthcare spending in the United States. And these reasons for the high costs include monopolies, also disease severity, so patients are willing to pay any price if they have a really complicated disease, and then research and development. It takes a lot of money to test this and do the clinical trial to prove its efficacy, as well as political power of the pharmaceutical company. So here we are in summary. So we want to think about these factors that impact public health policy, including law, regulation, program, and behaviors. And then we mentioned that balance between individual and public health interest, as well as different initiatives and delivery mechanisms and the policies that impact pharmaceutical supply. Thank you.